Well, thanks, folks. Thanks for your attention and interest in this. I'm going to speak today, and I think it's going to be a relatively short talk, although I'm not going to make any promises at the outset because who knows what's going to come up in my brain. But I'm planning to talk for a short time about the set of side effects that go by the name extrapyramidal side effects. These are relatively probably the most common side effect of the drugs that block dopamine receptors. The most common therapeutic application for dopamine receptor blocker, let me say that again, the most common therapeutic application for blocking dopamine receptors is the treatment of psychosis associated with schizophrenia. Most of the FDA-approved dopamine receptor blocking drugs go under the category of antipsychotic. However, some other drugs that are used in clinical practice, notably and particularly the older antiemetic drugs, are also dopamine receptor blockers because blocking dopamine receptors is a fabulously effective way to reduce nausea and vomiting. And you can also use these things. I've actually bullet pointed several clinical applications for dopamine antagonism, schizophrenia or psychosis associated with schizophrenia being probably the most common indication for dopamine antagonism. These days, it seems that bipolar disorder is increasingly common to see people with bipolar disorder being given so-called antipsychotic medications, which is an interesting thing to comment on. And here I'm going to go elaborating. Hopefully this will be interesting, because in the, say, 1996 and before, almost everyone with bipolar disorder diagnosis was given lithium. And from 1996 to the early 2000s, then it was Depakote or lithium. And the dopamine receptor blocker drugs were representing maybe about 10% of prescriptions given to people with bipolar disorder. The last data that I saw was from 2016, and the percentage of people with bipolar disorder who were managed with antipsychotic drugs rose to about 55%. So they've become actually the most common method of treatment for bipolar disorder. And all without the imprimatur of professional society recommendations. There's no clinical practice guideline that says that antipsychotic medications are the recommended first-line treatment. The dominance of antipsychotic medications as bipolar treatment reflects the success or the activity of pharmaceutical marketing, because there are so many modern antipsychotic drugs that are patented, still under patent protection, are branded, approved by the FDA for the treatment of bipolar mania predominantly, and are marketed for such. So there's the marketing dollars at work. They are also used and patented and on brand, on label and marketed for the treatment of treatment-resistant depression. And by the way, then, just to be a little bit snarky, if depression is treatable by adding a second-generation antipsychotic drug, then one wonders why they've decided to still retain the name treatment-resistant depression. I find that always a curious phenomenon. And why I harp on this is because words really matter, and to call depression resistant to treatment does a couple of curious things. One, it interestingly displaces the, if you will, blame for the failure of therapeutic success away from us or our deficiency of knowledge or skill and onto depression. It's not my failure as a clinician, it's the depression that was resistant. And it also suggests to everybody involved, patient, clinician, and family, that this depression is like ordinary depression. It's just a worse depression. And it may actually be that that kind of depression is fundamentally different in cause than ordinary depression. but labeling it treatment resistant puts a certain frame on everybody that makes us be more aggressive by using the same treatments just harder, when maybe we ought to use just different treatments because it might be a different disease process that happens to have the same top level symptom. Like I said, I don't know exactly what I'm going to say before I start saying it, but there's so much richness in the field of things worth commenting on. As I mentioned, the first generation of antiemetic drugs were entirely, first generation of antiemetic drugs included some very successful agents, which were dopamine blockers, and you can use these drugs to treat the, I'm sorry, I think I did a mistake there. And you can use these medicines to treat Tourette's syndrome. They're on label. For some of them are on label for treatment of Tourette's. Some of them are on label for the treatment of agitation associated with psychosis, agitation associated with autism, and they're off label as sleep aids, but drugs like Seroquel/quetiapine or other sedating antipsychotics are relatively commonly used to treat insomnia. They are off label, but still not infrequently used to treat personality disorders.
I didn't understand. I think you said to play voice messages. Is this correct?
Cancel. Sorry. I mentioned in my last talk, I have some technological challenges. They're also off-label for treatment of anxiety disorder. They're off-label for many things, but they're used extensively. And in primary care practices, many of you who are primary care clinicians may prescribe them for treatment-resistant depression. Certainly, America's pharmaceutical companies would encourage you to prescribe them for treatment-resistant depression. They're certainly marketing directly to consumers to ask their clinicians to prescribe them for treatment-resistant depression. And absolutely, certainly, you're seeing patients for whom they're being prescribed. So I think being aware of side effects is helpful, because God knows they are happening. And I can tell you from my own experience and from listening to patients and from reading discussion boards, a lot of people who experience side effects are not aware that they're experiencing side effects because they haven't had them explained to them, or it's good to have side effect awareness, because some of the side effects, because nobody should experience them if they don't have to. And in the case of the neurological side effects, they can, in many ways, the risk of their occurrence can be reduced. And quite often, if they do occur, they can be eliminated quickly and successfully, so that if the medication is otherwise effective, the patient can continue to enjoy their benefits and reduce the distress or the risk that may occur. Broadly speaking, from the dopamine receptor blocking drugs, antipsychotics, and so forth, you have this very large broad category: neurological side effects, which get the synonym extrapyramidal; metabolic side effects, which is a little bit euphemistic way of saying weight gain and its consequences. You could also say that weight gain and its consequences is an endocrine side effect, but I just said prolactin elevation counts as an endocrine side effect, and neuroleptic malignant syndrome. I'm going to focus on just the neurological or extrapyramidal side effects today. Extrapyramidal, it got the name extrapyramidal because psychiatrists like to be fancy. And the pyramidal system, the pyramids here refer to the pyramids of the medulla. This is the pathway that transmits voluntary motor signals from the motor cortex down through the spinal cord. So the pathway for voluntary movement goes from motor cortex through the corona radiata, down through the pyramids of the medulla, onto the spinal cord and into the muscles. So if I want to move my arm, those axons go from my motor cortex through the pyramids. But if my body needs to restrain spontaneous movements of my arm, And in moving my arm, I need to have fluid movement rather than jerky movement. And I need to have, the absence of tremor and other sorts of things. So these fine tuning of movements or restraint of involuntary movements, those involve neurological circuits whose axons do not travel through the pyramids. Those are thus called extrapyramidal. So the extrapyramidal motor functions are broadly, I call them fine tuning. They involve the restraint of spontaneous involuntary movements and of the fine tuning of tremor and the will to move. So that's how it got its fancy name. And just to be clear, we're going to talk now in this lecture specifically about the four main categories of extrapyramidal side effects: drug-induced Parkinsonism, dystonia, akathisia, and tardive dyskinesia. Drug-induced Parkinsonism, it looks like ordinary Parkinsonism. It's just caused by drugs. In ordinary Parkinsonism, also known as idiopathic Parkinsonism or natural Parkinsonism, I would call it, the pathophysiology is as follows. Cells that make dopamine whose cell bodies reside in the substantia nigra, those cell bodies die for reasons that are not entirely clear still to this day. But those cells that make dopamine, they project axons, and the axon terminals end in various structures in the basal ganglia higher up toward the nose. And when those cells are dead, then in the basal ganglia, circuits that control motor fine-tuning, those circuits become dysregulated, and one of the results is tremor. Other results are that the muscles start to become more rigid at rest. And because of dysregulation of muscle tone, then patients that experience loss of dopamine input to basal ganglia will have a stooped posture when standing. They will have, when they walk, their gait will be short-stepped. Occasionally, it can move to what's called a festinating gait. And a festinating gait is where you start off with short movements. Now I wish I had my video on. I'll try it and see how it goes. Okay. Nicole, I can see your face, so please wave your hands if it gets choppy. So a festinating gait is where you start off with short steps, but then the gait becomes larger and it sort of can progress to a gallop. So that's a festinating gait. That's not all that common, but it's common enough in Parkinson's disease that it gets its special name, and it's a gait pattern associated with Parkinson's disease. It's worth knowing about because it absolutely happens, and a lot of people don't know about it. So if you notice it, you'll be hailed as a genius, and you'll be able to solve an important problem. And also because of the loss of basal ganglia dopaminergic input, which regulates involuntary muscle tone, people with Parkinson's disease tend to have, they have like a mask-like face, they have reduced facial expression. And in severe cases, patients have difficulty rising from a seated position or getting out of bed. And in extremely severe cases, people can have difficulty moving at all. There are some famous cases or infamous cases in San Francisco in maybe it was the 80s, in which tainted fentanyl made in laboratories contained a chemical which turned up to be a neurotoxin very specific to dopamine cells of substantia nigra. So people who were using fentanyl for recreational purposes were waking up unable to move. It got the name in the media, the case of the frozen addicts, and it was one of the examples where epidemiology was able to solve a problem kind of quickly, and it was all traced to tainted fentanyl, and that led to the discovery of a neurotoxin called MPTP. But I find that case to be memorable because it illustrates a worst case Parkinson's scenario, and just to make it, I guess, to add color or interest to the story, at one point in my career, I was referred a case, came from a community hospital to the state hospital and I was told it was a 19-year-old woman who had catatonic schizophrenia. And now to add snark to the case, I was also told that this was a young woman whose parents were illegal Mexican immigrants, didn't speak English, and she was brought here when she was 2 years old illegally. So that was the case. And also in looking at the records, I noticed that they had done 2 swallowing studies, 2 of them. They didn't tell me about swallowing problems, but apparently she had some swallowing problems that they were trying to diagnose, and they were not successful. They found no explanation by swallowing studies for her dysphagia. So given that background, I did know enough Spanish to be able to I found a cell phone number for the mom. And so I left a message in my like 4-year-old equivalent Spanish and said, "This is Dr. Messamore, here's my number, here's my cell phone number, please give me a call and I'll arrange for an interpreter and we can talk about your daughter's case." And many notes from the referring hospital indicated, "Can't get a hold of mom, she doesn't speak English, blah, blah, blah." So this mom called me in 10 minutes after I left my message. She speaks perfectly good English. And I also got a history that told me that her daughter was experiencing mania, and that was her first manic episode. So then I was thinking, okay, catatonia is more common in mania than schizophrenia, so that. And then finally the girl came, and she could not rise from a seated position. She could not rise from the laying position. She was frozen, but she was also rigid. But she didn't have that waxy flexibility. She didn't have anything that looked like classic catatonia. I got the sense that this was, in fact, worst case Parkinsonism. I gave her a 0.5 milligram of Cogentin IM, and 20 minutes later, literally, she was skipping in the hallway and singing and telling me about how she owned the hospital and was signing my paycheck. So turned out that was a case of frozen Parkinson. It was of like total body, of like severe drug-induced Parkinsonism. That also explained why she wasn't swallowing, because she had probably actually it was dystonia of her throat that she was experiencing at that point, which was remarkable because she was on risperidone, not a very high dose, but it was sufficient to cause the worst case of drug-induced Parkinsonism and or laryngeal dystonia that I'd ever seen. So I mention that because it's interesting to hear, and also it illustrates maybe the next slide or another slide coming up that talks about dystonia and how it can be dangerous. Drug-induced Parkinsonism, how to deal with it if you see it in even a more subtle form. The first thing you can simply is just to reduce the dose of medicine. PET positron emission tomography studies are really clear, showing that you probably don't get drug-induced Parkinsonism until you have blocked about 80% of dopamine receptors. And PET studies are also pretty clear that you do not need 80% receptor blockade in order to reduce psychosis in somebody experiencing schizophrenia. You can actually, those PET studies suggest that you can reduce psychosis by blocking 40% of those receptors, or up to 70%. And if you get 70%, if you get 80% or less, you can reduce psychosis successfully and probably not cause extrapyramidal side effects like drug-induced Parkinsonism or dystonia. So by the time you see these motoric side effects, this is nature's way of telling you through muscle tone that you've probably exceeded the target necessary to reduce psychosis, and you can simply reduce the dose of medicine. Of course, if your patient is not able to get out of bed, or is experiencing painful muscle dystonia, or is having a disfiguring gait, or has a fascinating gait, or might fall, or other sorts of things, or if you simply just want to get them feeling better or normalize their appearance, then it's extraordinarily easy to do by giving them any antimuscarinic drug. And just to be a little bit clear, or cover some pharmacology, acetylcholine, where's my cursor? Acetylcholine has, broadly speaking, 2 different protein families that can function as receptors. One of them, one broad family of protein receptors for acetylcholine is stimulated by muscarine, and so that is called muscarinic receptor. Another entirely different category of receptors is best stimulated by nicotine. So there's another subcategory called nicotinic receptor. If you want to treat the extrapyramidal side effects from antipsychotic drugs, you'll want to block the muscarinic subtype of acetylcholine receptor. And benztropine is the favorite of psychiatrists, but you can also do it with Benadryl, which has the advantage of easy to acquire over the counter and so forth. And several others are equally effective. Any muscarinic receptor antagonist will do, and it can be effective at pretty low doses. There's another way to reduce drug-induced Parkinsonism, and that is with a drug which is not at all, or hardly an antimuscarinic drug. It's called amantadine. When it was first approved, its approval was as a flu treatment, and it went under the name Semetrel, I believe. It is, the flu history is quite interesting to discuss, but I won't. It remains to this day, still in the armamentarium of neurologists as a treatment for Parkinson's disease, and it can successfully do so. It is a bit of a mild pro-dopamine drug and also modulates glutamate signaling. And probably by virtue of its pro-dopamine action, that's how it can ameliorate Parkinsonism. I prefer amantadine these days because it avoids some of the cognitive impairing side effects of acetylcholine, of muscarinic antagonists, and I'll leave it at that for now. So there are two pharmacological options to treat drug-induced Parkinsonism, and the beauty of it is that they both work super fast, and you can also simply reduce the dose and treat it very easily. Dystonia is a sustained muscle contraction. Typically, it occurs in one or two muscles. It can quite often occur in the trunk. It usually results in some sort of postural disfiguration. So there can be a contraction or a torsion of the body. It can occur in essentially any skeletal muscle. And notably, it can cause pain, and it can be life-threatening if it occurs in certain muscles of the neck or the throat. So it can occur in the eye, that can be painful and spooky. It can occur in the larynx, which can, in worst cases, can impair breathing. It can occur in the pharynx, which in worst cases can impair swallowing. Intercostal muscles can also impair breathing. So these are rare but super serious. And now I'm going to tell another, this is why maybe you can tell my voice has gotten upset, because I've heard too many stories of people in psychiatric hospitals in which, like the most recent one happened in our community, where a elderly gentleman had been started on some antipsychotic medication. I assume it was for something related off-label, like an agitation kind of thing. And he was saying that he couldn't swallow anything after that. And then he continued to have some degree of agitation. Maybe it was because of akathisia, a sense of restlessness, which also happens from these drugs. Whatever it was, he wound up in a psychiatric inpatient facility where one would assume people who might have known better should have been recognizing this. But he complained to the staff about how he couldn't swallow. And I have on good authority from a person who was there and heard everything, that many of the staff were ascribing his complaints of dysphagia to anxiety or to attention seeking or various other things. And somebody, I think it was his wife, was raising the possibility, could it be that this medicine that was prescribed, in other words, this antipsychotic medication that had been recently prescribed, could be the cause of his dysphagia? Because according to wife, he never had a swallowing problem until he started the new medicine. Oh, no, these drugs don't cause swallowing problems, was the response that they got from almost everybody in the psychiatric facility. So the person who asked me was a student studying to become a nurse practitioner, and he was saying, isn't it possible, isn't it true that these drugs can cause swallowing problems? It is in fact true that it can cause swallowing problems. And if you have a swallowing problem immediately after you start taking medicine, that was a dystonia involving the pharynx almost almost certainly, and the test of it would be either to stop the medicine or to give a small dose of benztropine. I mean, I would bet, my family actually has a farm, and I would bet every acre of the farm that had they given that man a 0.5 milligram of benztropine, he would have swallowed every bite of his next meal without problem. So that's dystonia. Typically it's in, arms or trunk, but it is important to know about the less common, but because they're less common, less well known, but also more painful and more alarming and sometimes more dangerous side effects. And by the way, you've probably heard about all the warnings about against using antipsychotic drugs in the elderly for the control of agitation. And every antipsychotic drug has a black box warning that says, do not use this drug. This drug is not approved for the treatment of agitation associated with dementia in elderly patients because it's associated with increased risk, because this category of medicine is associated with increased risk of death. And that's true, higher doses, these medicines are associated with higher risk of death. Those deaths the causes of those deaths tend to be respiratory related. Probably that's because they're causing swallowing problems. And you're getting aspirations because of the dystonic effects of the muscles of the throat. That's the leading theory to explain that. Akathisia is far and away that many papers have been written about this that emphasize this fact that akathisia is the most commonly missed diagnosis of, I don't know if in all of psychiatry, but certainly it's the most commonly missed side effect. It's extremely commonly missed. I have several friends who are psychiatrists, and psychiatrists tend to be extremely good with the use of language. And so my friends, are in that crowd that know a lot of fancy words and can, choose words with very precise nuance. And these friends have traveled, and while traveling got various kinds of nausea experiences and went to go get treated for nausea and emesis, and they got treated with first generation antiemetics, dopamine antagonists, and they experienced akathisia, and they came back and just like couldn't stop talking for a while about how awful it felt, like ungodly awful, and how there was no word to describe precisely how exquisitely bad. I mean, not only how bad it felt, but the nature of the badness. So, I mean, these highly eloquent people could find no word in our language to describe exactly the feeling of it. But they were really emphatic. It was horrible to experience. So it's a special kind of suffering that in my own practice, I've found when patients describe feeling like icky, then if I say, does it feel like you want to crawl out of your skin? And then everybody says, yeah, that's the one. So it's just intensely awful. And it feels it feels squirmy. People describe it as, I feel like I gotta move, like I gotta wiggle, I can't sit still, like I want to crawl out of my skin. And eloquent people can't describe exactly how it is. And just think of if you're prescribing it to somebody who has schizophrenia or who has autism or who has dementia. People, are, even though the warning exists, it's commonly prescribed. So people may simply respond to akathisia by becoming more aggressive. Common scenario in my consultation world is a person shows up in the emergency department with some degree of agitation because of, who knows, urinary tract infection or appendicitis or delirium of some kind. Agitation in the emergency department is quite common. So it's also quite common to give some antipsychotic medication. Whether first or second generation, it doesn't matter. Akathisia is still a side effect risk. So the not uncommon scenario is that the agitated patient gets a antipsychotic medication in an attempt to reduce agitation, and then surprisingly, the person doesn't they don't respond to the medicine by reduced agitation. They seem to continue to be agitated or maybe become more agitated. So then they get another dose and the agitation continues, and then they get another dose. And at this point, they're getting actually more agitated, and then they get another dose. So what oftentimes happens in the scenario is they're experiencing akathisia. And the akathisia in a person who has communication impairment because of underlying cognitive impairment or because of delirium or because of whatever is, or because they just can't explain or don't want to explain, I feel so restless, like I could crawl out of my skin, or because they're now restrained, is just expressing this intense internal discomfort through agitation. So it can happen. And by the way, on the topic of akathisia, if you go and read the prescribing information for many of the antidepressant medications, you will see akathisia actually named, like spelled out in the prescribing information as a risk, or you will see it synonyms like restlessness described as a side effect. I mean, common side effect. Well, it's a known adverse effect from SSRI and SNRI antidepressant medications, and much speculation in the small literature around questions like, can SSRIs or can antidepressants induce violence, or can they even drive somebody to homicide? That literature quite often speculates that agitation, violence in people who take SSRIs who are not otherwise predisposed to agitation or violence may in fact be a manifestation of akathisia. So akathisia is serious business, and in the textbooks, it is described as you walk around a lot or you move, or it's described as a very obvious motor syndrome, and it certainly can be, but it is also these days in modern textbooks and in literature recognized to be also a very subjective experience that you can have almost entirely subjectively without really obvious motoric symptoms. So because it is so frequently not recognized, I think it's important to understand that anybody who's taking an antipsychotic medication it can experience akathisia, and they can also experience akathisia from antidepressant medications. And it is like an exquisite form of suffering, which people might report as anxiety or agitation. And sometimes that might result in increasing the dose of the medicine that caused the symptom. So just be aware. Treatment for akathisia it's really interesting it's weird. Akathisia is always listed as an extrapyramidal side effect, but pharmacological responses suggest that it probably shouldn't be considered to be one because it seems to respond in a different way. Textbooks say propranolol, and they always emphasize propranolol because of its CNS permeability. Compared to other beta blockers, propranolol seems to be preferentially better to get into the CNS. So propranolol is always there, and it seems to be tied in mentions with lorazepam or other benzodiazepines. So those are the textbook solutions. Not yet in textbooks, but seems to be reasonably documented in clinical studies in medical literature, are supraheptadine and mirtazapine. These are thought to work by blocking certain subtypes of serotonin receptor. And in my own practice, like I've seen many people who have not gotten one bit better from propranolol or lorazepam, and in these non-responders to textbook options, every single one of them so far has gotten better with supraheptadine. So it's been, in my own experience, at least with those individuals, a very good option. Mirtazapine, aka Remeron, is in the literature described to be quite helpful. In my own practice, I've seen several cases of Remeron that seem to cause akathisia. So sharing that with you. because it's so awful, I think we should be, inquire about it and act immediately, and treat it when it arises. Whether dose reduction helps is not really well established. It certainly makes sense to try it or to reduce medicine. Although with some studies of second generation drugs, people sometimes say that moderate akathisia does go away with continued use. So it's less clear exactly what to do with it if it's moderate and if a patient's getting benefit from the medicine. But if it's severe and it's an early onset thing, then totally just relieve it and look for a drug that's not going to be associated with such a severe response. Tardive dyskinesia is, ironically or coincidentally, I happen to read a lot of Reddit groups where people talk about side effects or various psychiatric things. And just like 2 days ago, somebody described having been given Geodon, aka Ziprasidone, the generic name, been on it for less than 2 years, and was asking the group, could this be tardive dyskinesia? Because apparently this person thought it was something that you get in your face, but the author was saying, I get these random twitching movements in my feet and sometimes in my trunk. And unfortunately, somebody who was claiming to be a psychiatrist said, that sounds like akathisia to me. And that to me sounds like actually a fairly classic presentation of tardive dyskinesia. So but the point I'm trying to make with this is that it actually can happen with second generation drugs like Ziprasidone, and it tends to be more common. Tardive dyskinesia tends to be more common when antipsychotic drugs are used to treat mood disorders. So I think it's important to mention to a primary care audience who may be using antipsychotic drugs to treat treatment-resistant depression that is a population at higher risk for experiencing tardive dyskinesia. And women are more likely to get TD than men, and also TD risk increases with the age of the patient. So like a worst case scenario for TD risk would be, the worst case scenario would be an old woman with depression who's now given an antipsychotic drug to try to boost the depression efficacy. So there's that. Tardive dyskinesia is something that typically we think of as developing after many, many years. It can actually develop in as soon as 3 months of continuous use. That would be an outlier, but cases have been described. As opposed to the tremor of Parkinsonism, which is rhythmic and about 3 or 4 beats per second, tardive dyskinesia is not really rhythmic, or if it does seem to have a rhythm, it is much faster than 3 or 4 beats per second. It's usually jerky and random, and it can occur in it tends to be either a jerk or a writhing motion. So if it's in my finger, it would be like that, or it would be like this, and then like a snaky thing, jerk and maybe a movement. It can be sometimes in bad cases, they can be like jerky and then sort of a compensatory complicated movement, but it usually starts off as just simple jerks. And they can happen anywhere in the body. Yes, it's common in the face. Any muscle of the face can be affected. A not uncommon presentation, commonly missed, is blinking. So higher rates of blinking should elicit some concern. It's very useful to just have a person sit still and observe them for 30 seconds and look to see if there are any random, unexplained jerky movements of their limbs or their feet or hands or their toes or fingers. With tardive dyskinesia, it is common for movements to be unmasked. So if you have a person, like if you look at their tongue, for example, tongue can be a common site of dyskinetic movements. So open your mouth and you can see nothing. But if I open my mouth and I move my finger, then I can start to see dyskinetic movements of my tongue. So I move one area of the body, and then I can see dyskinesias in other areas of the body. You can also see unmasking of dyskinesias when you take away the drugs. So those are things to look out for. TD is a big concern because it can become permanent. There's the worry literature would make you think that once it happens, it's always going to be there. It does not have to be that way. The worst case estimates that I've read are half of cases of TD will not subside, but the range is also, I mean, it goes down to 30% of cases won't subside, meaning that 70% of cases will, particularly if it's caught early. The best way, I mean, there are now treatments for tardive dyskinesia. There are 2 approved drugs for it, and there are some other drugs that have, a small bit of literature that could be used off-label that would be much cheaper. So there are some options that could be helpful to reduce TD symptoms if they do emerge. It's far better and easier to try to prevent it in the first place. And the easiest way is to not use antipsychotic medications if you can avoid it, which is partly why I earlier emphasized trying to not use, well, I was a little bit snarky about when I talked about using antipsychotic medications for sleep, and pointed out that not all depression requires antipsychotic drugs as treatment, because with depression in particular, there are several very good evidence-based psychotherapies or other strategies to address it that don't involve antipsychotic drugs. So if you can avoid using antipsychotic drugs, by all means, please do. And if a person has gotten better with antipsychotic drugs, that's fabulous. We should at that point start to look for the lowest effective dose, and at some point always consider whether we can eventually reduce that dose to 0. For people that do require continuous use of antipsychotic drugs, again, trying to achieve minimal effective dose is good. And for those, then keeping evidence-based pharmacologic treatments in mind would be a good idea. And that is the end of comments on that topic, which I will pause and thank you for your attention.